want to welcome everyone to Epilepsy Foundation's webinar on rescue therapies for children and adults. We'll get started in a few minutes, but we'd love to see where everyone is joining us from. So if you want to share where you're joining us, you can toss it in the chat. I'm here in Chicago, and our panelists, they'll share where they're from, but we're joining from all over. So just toss that in the chat. We're also going to want your questions during the webinar, so please submit them using the Q&A box, and we'll ask our experts those questions during our Q&A. So we'll just give it a few more minutes here, and we'll get started. Welcome. We're doing our webinar on rescue therapies for children and adults tonight, so we're glad you can join us. Like I said, if you have questions, please put them in that Q&A box, because right now we're getting that chat box figured out right now, and we'll ask your questions to our experts later on in the evening. So the mission, of the Epilepsy Foundation is to lead the fight to overcome the challenges of living with epilepsy and to accelerate the therapies to stop seizures, find cures, and save lives. And we are grateful to the speakers we have joining us tonight and to the sponsor for tonight's webinar, who are Neurelis and UCB. My name is Allison Kukla, and I'm the Senior Program Manager for our Programs and Partnerships team here at the Foundation, and I'll be moderating tonight. I'm really excited to have you all joining us, and I'm pleased to have with me Ms. Nancy Santilli, who's an experienced epilepsy nurse and educator, and Dr. Larry Hirsch, who is an epilepsy specialist. We will be discussing new options for rescue therapies to stop seizures and who could be helped by them. And as I mentioned, we'll have time later on to answer your questions that you have about rescue therapies and other things you hear discussed tonight. But I want to take a few minutes to allow our panelists to introduce themselves and hear about their expertise in the area. So if you both can share a bit about your background in epilepsy and what got you interested in, rescue therapies, that would be wonderful. So I'll start with you, Nancy.
Well, welcome this evening. It's great to be here and certainly a thrill to be talking about this. As you mentioned, I'm an epilepsy nurse specialist, have been involved in epilepsy for most of my life. And in terms of rescue therapies, I was involved with the original trials for rectal diazepam gel. So I feel that I have seen the evolution of the concept of rescue therapy in epilepsy for over 20 years now. And I'm so excited that there are some new options for individuals living with seizures to take control of when they have seizures, to get the care that they need, and to have the life they wish to live. So happy to be here.
We're glad to have you here. And then Larry, can you tell us a bit about yourself?
Sure. I'm Larry Hirsch. I'm a neurologist and an epilepsy specialist at Yale in New Haven, Connecticut. And I'm interested in all aspects of epilepsy care, but one that was gravely missing for the past couple of decades was really a convenient form of rescue medication. So fortunately, in the past few years, not only do we get one, but we have multiple options for that. So I'm thrilled to be able to actually tell people about them and that we have some convenient forms available.
Well, thank you both for being here tonight. And I see we have the chat back up and running. So, and people are sharing where they're from, and we have folks from all over. So keep putting those in the chat and sharing your questions as we start the discussion with Nancy and Larry. So first question, Larry, I know rescue therapies can be, kind of a big topic. So let's start by defining some, terms for folks. Can you define seizure cluster, rescue medicine, and a seizure action plan for everyone tonight?
Sure. So I'll start with seizure cluster. So that's kind of become the accepted term. There's a variety of other terms for it, but whether it's seizure flurries or the actual US FDA uses the term acute repetitive seizures, they're really all synonyms for sudden increase in the frequency of seizures that's unusual for a given patient. The actual definition varies from setting to setting. for most of the studies and for the nasal rescue medications we're talking about, it usually refers to multiple seizures within a 6-hour window. Sometimes in some studies it's 24 hours. There are multiple definitions, and it really is customized for a given patient on what's a cluster for them. It is distinguished somewhat from what's called status epilepticus, which is just prolonged seizure activity. Or if you have back-to-back seizures without waking up in between, that's considered status epilepticus, which is even more of an emergency than seizure clusters. On the other hand, in the practical sense, we will often be using the same rescue medication for either, even though they're formally approved only for seizure clusters. There are some other definitions you should be aware of. There are slower seizure clusters, such as people who have more seizures in, for example, in the week around their periods. That's another form of seizure clusters, but where you usually just oral or by mouth medication is adequate for treating that kind of cluster. And then there's statistical clusters as well. I don't think we'll get into that too much. So that seizure cluster is really any increase or sudden increase in seizure frequency. Rescue therapy is distinguished from maintenance therapy. So maintenance therapy refers to the medication you take every day for your seizures. And rescue therapy is something you take on top of that due to an increase in seizure activity. So something you don't take regularly, only when something out of the ordinary is occurring. And then a seizure action plan is what we're hoping to get for virtually every patient out there, so you know what to do if you have a seizure or a prolonged seizure or a seizure cluster or anything out of the ordinary. You'll know what to do, and that's really a written plan on when to take a rescue medication, exactly which one, what dose, how to take it, when you can repeat it, when you need to call 911, all of that in one place. So those are kind of the basic definitions. And let's see, Nancy, did I forget anything?
No, I think, Larry, you covered everything. The one thing I know, when we were working on the seizure cluster initiative with EF, that they went out to a panel of people and asked them kind of common terms that they might use for this. And we also heard many of the things that you said, but we heard things like, oh, they're my bad seizures. And I think the other thing that I often hear is people get confused and think seizure clusters are a new kind of seizure instead of, I think what you were inferring, that seizure clusters or flurries of seizures can occur with any seizure type. It's not a new kind of seizure. Allison, was there any other terms that you can remember from the survey that kind of stuck out that maybe we should call out here that people might use to help trigger in their mind that, oh, I am having those, especially if they want to go and talk to their doctor about this?
No, I was going to mention what you had said that came out in the survey was people calling it my bad seizures or, something like that. That phrasing that had come out in the survey, identifying it as, not their typical seizures, but, those bad ones that happen sometimes.
Yeah.
And then Brandy had put in the chat a resource to the seizure action plans where you can find links on how to, and templates on how to create seizure action plans, which we'll get into a little bit later in the webinar, but that link is in the chat already. And then our next question is kind of a follow-up. Larry touched upon it a little bit. When is the rescue therapy used and what are the risks? I know you talked about it can be used around, maybe a woman's menstrual cycle and things like that, but I want to put that question to you, Larry, to start.
So I think the key there is to really individualize it and have that as part of your seizure action plan you make with your doctor or the doctor's team. I could say something like what is the most common. The most common is if people have multiple seizures within a few hours, that might be a time where they would take a rescue medication. But it's very hard to make a preset rule. So someone who has a small seizure every few hours very often, or every other day or something, you may not want a rescue therapy. Where as someone who never has 2 seizures in one day, if they have 2 in one day, you may want to do it. So it's really individualized. And then I will mention for prolonged seizures, I also have my patients take it, even though that's off label, because then that's technically status epilepticus, whereas all the rescue meds we're talking about today are approved for seizure clusters. And then as far as the risks, I must say there've been extremely little in the way of risks other than some sedation and some nasal irritation for the nasal ones, which we'll talk about in a bit. But people worry about taking some of these acute medicines. They're all in what we call benzodiazepines. So whether it's diazepam, which is Valium, or midazolam, which is a related drug, people worry about suppression of breathing, but it's actually extremely rare. And in the long-term extension studies for both of the new nasal drugs, there were really no serious adverse events related to breathing. And in literature on status epilepticus, taking one of those drugs actually helped breathing. You're more likely to have a problem if you did not take it than if you took it. And that's because seizures can affect breathing. So in general, if you're having seizures, it's safer to take these medicines than to not take them. I don't know if you want me to get into the specific medications yet, or
Yeah, I was going to say, we had a question come in that was the next question I was actually going to ask. Someone's curious about what is actually in a rescue medicine and if it's different than the medicine someone would take every day. And then, kind of what we are going to talk about, what are the new medicines?
right. So yeah, one form of rescue is to just take extra of your regular medication, and we used to do that more often. But now that we have these more convenient drugs, we're tending to go to the one specifically approved for seizure clusters. So there's really, I guess, 3 main ones now. One is old, so that's Diastat, or the rectal diazepam gel. So that's been around for decades. And it's great for young kids, and it's still commonly used in young kids. I must say, as someone who takes care of mostly adults, I virtually never use it because it's so difficult to give and socially has a lot of issues. The other 2 that were approved in the last 3 years, they're both nasal form. So one is nasal midazolam, and the brand name of that is Nasalam. So that was approved in 2019. And that's just a nasal spray, just one shot. It's one push, you get the whole dose. And then about 1 year later, in 2020, we had approval of nasal diazepam. It's a very similar medication. A slight difference in how fast they get in and how long they last, but very similar. And same thing, that's a nasal spray. You take 1 or 2 doses with that. With the first one, with Nasalam, it only comes in 1 dose size, and it's approved for ages 12 and older. But with the nasal diazepam, that's the brand name of that is Valtoco, that's approved down to age 6 and has multiple dosing sizes, which is easier to adjust for younger kids. So those are fantastic options. The differences between them are fairly small. There's often practical ones, either financial or dosing. They'll make you pick one over the other. But they're both great advances, and they're much better than the off-label use of midazolam we were sometimes using prior to that. And these are pretty easy. They are easy to carry around. And I mentioned some of the safety. Some people get some irritation in the nose from taking a nasal spray, but surprisingly few. Some people get a little sedated, not surprising, that can be a sedating medication, but very few people decided to not take it because of that. And seizures themselves can be sedating, so sometimes it's hard to tell which it was. So overall, they're extremely useful, easy to give. One other point is it can be given by the patient. So if they know they're in a cluster and they're between seizures, they can take it. Some people have a prolonged warning to their seizure where they're actually fully alert and can give it to themselves. And it obviously can be given by other people too, for caregivers, and give them nasal spray. So why don't I stop there, see what Allison, you and Nancy want to add, and see if you have questions about that.
Yeah, Larry, I think it would be good because sometimes I know I've gotten this question. Individuals are afraid to use it because they think they're going to get addicted. Can you speak a little bit to that? Because again, they're prescribed because their physician or practitioner felt it was useful to them. You know, is there any
Right.
reason for them to hesitate to use it?
Short answer is no. So we do try and limit these. I think officially they say not to use it more than something like 3 days a week and 5 times a month, but you can actually use a little more than that and not worry at all about addiction. Particularly the midazolam one, that's the nasalam. That's a very short half-life drug, so it's really out of your system in a couple hours. So yeah, we don't use these every day. That's why they're not part of why they're not great as maintenance medications. Is when you take these as maintenance, you do get some form of either tolerance, meaning it doesn't work as well at the same dose, or addiction means there's some kind of withdrawal as you stop it. That is true if you take these orally every day for months, but it's not true if you just take them as rescue meds occasionally as we prescribe these.
Thank you for that great overview of all the meds. I know you've covered a lot of the questions that have been coming in the chat. So I do want to go to Nancy next because some folks have been asking about this, and I know Nancy will, be able to give a good overview of this question. How would you encourage folks to talk to their doctors about rescue therapies if that conversation hasn't happened yet in a visit?
Well, first, I think you have to just ask the question and don't be afraid to ask the question, is a rescue therapy right for me, especially if you're still having active seizures. It is a conversation you should have. You can do that through your My Health now, which is very convenient. If you don't have a My Health portal to go to, or you're not inclined to use it, you can always leave a voice message for the HCP, the healthcare provider, or the team that you're working with. I think another really good way to help the conversation is to start pulling together what your seizure action plan is. It's a great tool, but it's also a conversation starter in my mind, because if you start to develop that and fill that out, there is a section that will ask, is there a rescue therapy that you would want an individual who might be assisting you to give? And it allows you to start that conversation with your healthcare team if you feel awkward doing that. The other thing I think you can do is, certainly as you go for visits, is to write your list of questions, whether that's on your smartphone or it's on a piece of paper or whatever. But I think when you do that, typically, and Larry can jump in here, is that doctors, your clinicians, who's ever taking care of you, are going to want to know, well, let's talk about the frequency of your seizures and what's going on. So you really should be keeping a record, whether it's on your phone calendar, you're using, some sort of diary, if you've got an app, if you use wearables to help you keep track of that. But if you ask the question of your HCP, then probably the next question they're going to ask you is, let's talk about the frequency of your seizures. So being prepared, ask the question, absolutely. You should ask that question if you feel it's something for you, but be prepared to help your healthcare team make that decision with you by having a record of your seizures. And I know Brandy is going to, put some tools or resources for you in the chat. I would strongly recommend you to look at those because, we've already started to talk about the seizure action plan. The Epilepsy Foundation has a great resource there for you. They have a fillable form that you can complete and download. You can download it directly. The beauty of what they offer is not only do they have it in English, but they have it in Spanish, Korea, Simple Chinese, Vietnamese, and I think there's another one, but I know they're always adding to it. So as you think about your circle, and we're going to talk about this, the village of people who may be helping you, you may have an English version for the school, but it's also great to have maybe a Chinese version for your relatives who may also be assisting you, or your loved one or yourself if you were to have a seizure. So strongly recommend you go visit it, use it as a communication tool to help you in having these discussions with your HCP or your healthcare provider. I'm sorry, I keep saying that. And then also with others, because it really does help us all get on the same page. I don't know, Allison, did I miss any resources there that are important for people that the foundation may have to offer in this regard?
No, you covered it all and gave a good overview, and fill in the chat with all the links there that I hope people are clicking on and getting access to. So no,
Yeah.
that was a great overview. Thank you.
Maybe you be comfortable sharing, because I think you started the conversation with your doctor. So if you are so inclined, maybe you might share it with our audience tonight. I know it's always good to hear directly from someone else who's done this.
Yeah, definitely. I don't think I included it in my introduction, but I'm a person with epilepsy. I've lived with epilepsy for 16, 17 years now and still have active seizures. And as Nancy shared, as she knows from work that we've done together, that, I was the one that started the conversation about rescue therapies with my provider because, I was still having seizures and I had learned about rescue therapies, but it was never something I talked with my provider about. And it seemed important because I was filling out a seizure action plan and I saw it on there and I didn't know how to fill it out because I hadn't had that conversation. And so I brought it up with my provider asking, is this something I need? How should we, handle this? And, it was a really great conversation because I felt, my care was improved by having that conversation and that we were able to have a very open and honest conversation with my provider. And I was, grateful to be able to have that conversation with him at the time. Because like I said, I felt that my care improved. My husband was part of that conversation too. And so he was aware of, what we needed to do if we ever needed to use my rescue therapy or anything like that. So it just really opened the door to another level of care that I didn't have for many years as part of my, seizure journey and all of that. So the tips that Nancy gave, I would encourage, having that conversation with your provider if you haven't had that conversation yet, because I know it just made me feel a lot better in my care. So hopefully that you're able to have that kind of conversation as well.
Yeah. And I think the other thing too is when we did the survey, Allison, I'm sure you'll remember this, is that when we went out and we asked both providers and other allied health professionals, and then we asked, people living with epilepsy whether they had epilepsy themselves or they were, supporting someone who did, I think everyone came away from that discussion and the survey results to say, this isn't a one and done conversation. So it's something that you should periodically be discussing with your providers, your team, if you're still having active seizures. So don't think if you did this conversation once, it's like, oh, check the box, I'm done. But more, at each visit or interactions as appropriate, revisit the conversation, because we know your epilepsy changes over time, your experience with seizures, your life changes over time, and this could evolve with you. So,
Yes, definitely.
yeah.
So, we have been getting a few questions I want to jump to before we talk about how to administer and things like that. And maybe I'll toss this one to Larry first, because you had touched upon, how long rescue therapies last in the system, but some people are asking, what do they specifically do to rescue the patient from who are experiencing the seizure emergency? How does the med stop the seizure?
Yeah, so I actually can see bunch of the questions. So there were several on the timing. So yeah, they do get in fast within a few minutes, but they're mostly used to prevent the next seizure rather than stopping the current one. There are some that may be coming in the future that are even faster, but for now they take a few minutes to really kick in. So they're mostly preventing the next seizure, not the current one. And then as far as how long they last and stay in the system, there are a couple of questions about that. It varies a little bit. The Nasalam or midazolam one is a little faster, so that's gone in a few hours. And the diazepam or Valtoco stays around longer for many hours. So that actually, if you want more protection 8 hours later, then the Nasalam's not going to give you that. You would need something else. The other point is oral medicines are still worth a lot. And if you have one that's working great and your seizures are not super close together, in general, I think of about an hour. If there's always an hour more between them, then the just oral by mouth medication is often completely fine. And then, so how do they rescue the patient? It's mostly they're preventing another seizure. And we know that using rescue medications can decrease seizure clusters. It can decrease that getting even worse and progressing to status epilepticus, decreases emergency room visits. We know seizure clusters and status are associated with all kinds of other things too, including increased costs, increased emergency room visits, more injuries. If you look at seizure-related injuries, having clusters is always a big risk factor for that. And it's also been shown to get people back to normal faster. So if you want to get back to school or get back to work or whatever you're doing, taking a rescue med helps with that. And it not only helps the patient, it helps the caregiver too. There have been some nice surveys on that as well. So you're not just treating the patient when you're stopping clusters, you're helping their caregiver too.
Thank you for answering all of those questions that we had come in. I do want to get to about delivering a rescue therapy and who should be prepared to do that. So Nancy, I want to turn to you. How can you get trained to deliver a rescue therapy?
Yeah, and before we get started, I think Larry mentioned this, but the 3 rescue therapies that have been approved by the FDA have all been approved for use by a non-medical person. So I think there's always this notion that, this is hard, or, only certain people can use it, but the studies were designed so anybody could, with some basic training, could learn to administer this. There are instructions with all the 3 medications that are approved by the FDA. They have pictures with them. So if you're more of a visual person, you can open up your box, look at that, read it. But if you're in the process of trying to even decide, like, could I use this? Is this something right for me? The Epilepsy Foundation has a great video on how to administer not just the rectal, all the medications that are approved. So I would say go watch that video. And if you didn't get it, watch it again. All the companies that offer these products have videos on how to administer them on their websites. And at least the two newer products, they will offer training kits. So you can contact the companies, you can get a training kit shipped to you that will have an example of the product, but not the product in it, so that you can actually practice, put it in your hands, practice using it, right? So that you get the feel for it. The one thing I would say with the new nasal products is, and I'm sure this is the same situation with the rectal diazepam gel, you want to practice on something, because if you've never done this before and the first time you have to administer it, if you're nervous, you could do it wrong. Just because, it's something new, and I always feel like dry runs are always good, and just making sure you get it in the tip of the nose before you deploy it is really helpful. I have heard that some individuals, are so anxious to administer it that they deploy it before it's actually in the nose, and then the medication goes up in the air. And I think that also happened in some instances with the rectal gel too, that you really have to get it inserted to get the medication. But there are plenty of videos, there's print materials, etc., and everybody should really just take a look at them, walk through what you would do, ask for a demonstration kit or a dummy of one of them, and practice yourself. If you're going to train your village to do this too, and everybody has a village of people in their circle, whether it's family, friends, co-workers, you show them, so that they get very familiar. They know where you carry it, they know how to use it, and that should be all part of your seizure action plan. What to use, when to use it, kind of how to use it, and what to observe for. And again, I'm going to go back. These were approved for use by non-medical people. So teachers, coaches, the bus driver, the school administrator, the camp counselor, your close family and friends that you spend time with, that you feel comfortable talking to about, so that they could assist you. Again, this is to try to make sure your life isn't limited because you're afraid you might have a seizure and someone wouldn't know what to do. But, seizure action plans are, as I said, a good conversation piece to help you get there, to show people what to do. And I think most people are happy to jump in and help. Did I miss anything, Larry or Allison, that we should have covered?
No, and I think
you covered it.
Yeah, and emphasizing the importance of, everyone's village and support network, and making sure that they're, trained and know what to do.
Yeah. I will put a plug in for the seizure first aid videos too, because I think it's always good to look at those, because that is part of seizure care, right?
Mm-hmm. Definitely.
Yeah.
We did have a question come in that I'm going to ask. I'll ask Larry, since I asked Nancy the last question. Can you address the shelf life of the nasal rescue med? Is there anything folks should be aware of there?
No, they've actually been tested in a range of what would be considered normal temperatures, and for many months. So they're actually nicely tested and have expiration dates. The only thing I'd be careful about is leaving it in a hot car. That's probably something that has not been tested, and you get really high temperatures there. So I don't know if there's any loss of efficacy in that. There's no danger in using them after they've expired or any of those conditions have happened. They just might be a little less potent. So if you still have that and nothing else, they're better than nothing. But if you start to get to near the expiration date, or you think it was, left at the beach in a car that got up to 150 degrees, you might want to get a new one.
Mhm. Yeah, Larry, I might add too that because school's starting, some of the schools I know require that you have a full year of dating on a product if the parents bring it into the school system. And they sometimes will go by the date on the prescription, and all pharmacies will say, don't use this product after, it's usually 12 months from the date of the fill. So I just bring that up because I know school's starting and a parent might have some medication at home that's still good, but the prescription says that you can't use it after December of this year. You may, even though it's an ongoing prescription, you may just want to be aware of that. And if there's a need to get a new label on it, that it can be good for the whole school year, if that's what's been prescribed by your provider, that they will accept something, or you're going to have to switch it out. I don't know, Allison, if you've gotten any calls about that at the foundation, but I know that I've run into that with some of the folks I used to care for.
I'm not sure if we have, but yeah. We have a question that I would curious, your input on it. Someone says that their son is very digital, asking, is there an app that they can keep this information on? Like, is there a digital seizure action plan or something like that? I would think maybe saving the seizure action plan on their phone, but are either of you aware of, or have you had patients keep this information in a digital format?
I've heard of people keeping it on their phone and then having it under like an icon. A lot of phones have emergency contact or emergency information or health information, putting it there. Or you could just take a picture and make it a favorite that someone could pull it up. But again, whoever's going to look at it, you need to tell them how to get into your phone and how to access it, because all of us have locks on our phone. But I don't know of a special app.
Yeah, there's certainly a lot of good apps now that include that you can do your seizure diary and keeping all your meds on, including rescue med. I don't know if the full seizure action plan, how detailed you can get on those. But we can certainly request they add those to all of those. So yeah, there's a bunch of apps. Some people are mentioning some of them in the chat. The one I hear the most being used now, and this good one, is Seizure Tracker. And that's something you can give your doctor access to as well, and you can see charts of their seizures and meds for the last several years.
Okay. Thank you for that input. I know it was an important question that came in, so I was curious if you had insight into it. Question for you, Larry. What should you do if the rescue therapy doesn't work to stop someone's seizures?
So that should be part of your clear action plan, is if it doesn't work, can you give another one? And in general, a second dose can be given for all of the meds we were talking about. And then at some point, though, if those are not working, that's where you might call 911. In general, we say for a seizure lasting more than 10 minutes, we certainly want to do that. Or if you've given the second dose of rescue medication and they're still seizing. But again, that really needs to be individualized. So definitely talk to your doctor about that. There's a somewhat related question there about if you need to use your rescue medication too often, more than you're supposed to be using it, what should you do? And that's the time where you really want to work on your maintenance medications and adjust those, because or find some other approach to your seizures, whether it's surgical or a device or one of those things, because that's just a sign that your seizures are obviously poorly controlled. So yeah, you don't want to be, this isn't something you can be using every day because it will stop using and it'll stop working. I guess I'll make the one up, but I don't think we mentioned that that is another form of rescue therapy is to, if you have a vagus nerve stimulator, you can actually swipe the magnet and get an extra stimulation with your vagus nerve stimulator. And similarly with the deep brain stimulator, there's a little remote, you can give an extra stimulation. So those are additional forms of rescue therapy, obviously not rescue medications, but another form of rescue therapy.
Yeah, and that's what I was going to ask as a follow-up too, since we've been talking about only medicines, what other rescue therapies are there? So, and you
Yeah, those are the stimulators. Yeah, those are the only other ones that are specifically designed to be used as rescue therapy that I'm aware of. And obviously you can use oral. We talked about that before.
So we just have a few minutes left here for questions. So if you have any more questions, please toss them in the chat here. Looking to see, we have some folks from Canada and also Australia joining us, which is exciting. Folks from all over. Trying to see questions here. Someone was asking if these rescue therapies are available in Canada or Australia. I don't know, Larry or Nancy, you want to address that question?
Not to my knowledge.
I don't know about the new ones. We're talking about the nasal exact ones. There's a lot of countries where either buccal, so between the cheek and gum, midazolam or diazepam of some kind is approved, particularly in Europe. I think in Australia as well.
I think
if somebody's on from Canada, maybe they can answer.
Yeah, I think some countries, because that's how the diazepam rectal gel kind of notion got started, is that they were using that in Europe. And because I remember seeing some delivery systems, but I don't know if that's how prevalent that is now.
Yeah, I can tell you one of the nice things about the nasal formulations is they're much more concentrated than some of the prior ones, and including the ones available in Europe. So it's just one spray, a very small volume with very good studies on absorption, and again, how long it lasts just carrying it around for many months. So I don't think those things exist for like the buccal midazolam formulation. Yeah, I think people have asked about specific medications, if it's okay to take it with it. I'm not aware of any medication where you cannot take these rescue medications. It's completely fine, including with ethosuximide, including if you're already on a similar drug, benzodiazepine, whether it's clobazam, which is Onfi, or if you're already on something like clonazepam, these rescue medicines still seem to work. Sometimes if anything, you might need a slightly higher dose to get the same effect, but they're safe.
We had one last question come in before we close out the webinar tonight. We know that there's been a shortage of the rectal diazepam. Do we know the status of that shortage?
What I know is the shortage is still in place, and it's my understanding that some dosages may not be made moving forward. So I think that hasn't resolved itself at this point in time. And I don't know how much of it will get resolved.
Yeah, I don't have any more information.
Yeah.
Thank you for that information. And then if anyone has questions about that too, you can always call. I see Brandy put our helpline number in the chat. So if you have questions about that, you can always reach out to the Epilepsy Foundation 24/7 helpline with questions. So just want to thank you all for joining us for this wonderful discussion tonight and your support of the Epilepsy Foundation's mission. And a special thank you to Dr. Hirsch and Ms. Santilli for joining us and sharing your expertise with us this evening. So thank you both for your time tonight.
Thank you very much. Happy
you.
to do it again, and apologize to anyone whose questions we couldn't get to. Looks like we'll have to do it again.
Yeah, I was gonna say, I know we couldn't get to all the questions, but I want to share a couple of resources before we close out this evening to make sure you get everything. If you found the value in this webinar, we invite you to make a donation of any size to the foundation so we can keep doing wonderful programming like this. And the webinar has been recorded and will be posted soon on our YouTube channel. So you will be able to access it along with our other videos on many other topics. And as we talked about our seizure first aid certification, you can take that to increase your knowledge, skills, and confidence in recognizing seizures and safely administering seizure first aid. And participants who successfully complete the course will receive a 2-year certification in seizure first aid. And then also, as we discussed tonight, we have our training for school nurses on using rescue therapies. The program is designed to provide school nurses with information and resources to gain a better understanding of using rescue therapies with children and youth and supporting them in the school setting. So you can find those on our learning management system, and that link was shared in the chat. And lastly, we just want to thank our sponsors of tonight's webinar, Neurelis and UCB, for their support of our mission to raise awareness and provide educational opportunities like this to the community. And as always, as I shared, you can contact the Epilepsy Foundation 24 hours a day, 7 days a week through our helpline at 1-800-332-1000. Or in Spanish at 1-866-748-8008. You can also email us at contactus@epilepsy.com. So thank you again for joining us this evening. Thank you to our speakers, and we hope to see you soon at a future webinar.